I'm going to go ahead and introduce our speakers for today and the exciting topics. So we have two speakers tonight. First, I'll introduce Mike Studer. He's a PT who has lots of initials and letters behind his name. He practices in Oregon and has been a PT since 1991. He's board certified in neurologic PT in 1995. He was recognized as the Clinician of the Year in Neurologic and Geriatric Academies of the APTA and received a fellowship in the APTA in 2020. Mike was awarded the Clinical Excellence for Clinician of the Year award by the Academy of Neurologic PT in 2011 and received the same distinction from the Academy of Geriatric PT in 2014. He holds both a patent and trademark in dual task rehabilitation. Over his career, Mike has authored over 30 journal articles, 6 book chapters, and presents internationally on aging, stroke, motor learning, motivation and rehabilitation, cognition, balance, dizziness, and Parkinson's disease. Awesome. And then our other speaker is Dr. Rob Winningham, PhD. He has nearly 20 years of experience researching applied memory issues, and for the past 15 years has conducted research on older adults and ways to enhance their mental functioning and quality of life. Most recently, he's been helping LinkedSenior.com create video games and interactive activities specifically designed to enhance cognition. He's a full professor and chair of the psychology division at Western Oregon University, where he manages both the psychology and gerontology departments. Welcome both Mike and Rob. We're so excited to have you.
Hey, great to be here. Thank you, Erin.
Yay, thanks for doing this free webinar for everyone in our neuro community. And thank you all for joining. We're excited you're all here. So go ahead and use the chat for any questions that you have. We'll keep an eye on it and keep yourselves muted so that we don't interrupt the recording or the presentation. And why don't you guys go ahead and take it away?
Great, thank you, Erin. I'll get us started here. So to kind of give you an overview of what we're going to do today, we're going to begin with executive functioning, defining executive functioning, talking about why it matters, and then looking at how we can maximize executive functioning in a number of different conditions and stages of life. We'll look a little bit at the benefits of physical exercise on the brain. In the past 10 years, a lot of research has been done on the effects of physical exercise, different types of physical exercise, and more recently on dual tasking. We'll define dual tasking, what it is not, functional consequences of dual tasking, looking at some of the conditions that can be treated with dual tasking, and we might be able to maximize the efficacy of our treatments if we can incorporate dual tasking in many different populations. So looking at a number of different applications. So it'll be an exciting presentation and very cutting edge. But first, I really want to begin with a definition of what executive functioning is. My background is actually in neuropsychology, and I've heard other neuropsychologists say that it's almost easier to define what executive functioning is not, as opposed to what it is, because it encompasses everything. The word executive actually comes from like how an executive or a CEO would control different aspects of their company. The executive functioning, largely your frontal lobe functioning, controls different aspects of cognition. But to define executive function, I would say it certainly has to include attention and the different types of attention, be it selective, sustained, divided, or alternating. But it also includes inhibition. Part of inhibition, which means not doing something, of course, is cognitive inhibition. I hope while we're talking that you're not thinking about something else. That level of cognitive disinhibition would affect learning. We all do this, and we'll go think about something else for a moment. Hopefully we have the awareness to kind of bring it back in, particularly if there's a safety issue at play here. But we also have behavioral or response inhibition. It's one thing to not think something, it's another thing to not do something. I spent a lot of my career working in assisted living facilities, working in skilled nursing settings, and actually that behavioral inhibition is key. Because if you're living in an assisted living environment and you cannot control your behavior, and you're doing things that are harmful to others, scare others, and really negatively affect that environment, you often need to go to a higher level of care. So that can really affect quality of life. Executive functioning also includes problem solving, reasoning, planning, and working or short-term memory. That's what's on your mind at any given moment. And this is important because executive functioning determines quality of life, even for a child. Executive functioning disorders might lead to attention deficit disorder, attention deficit hyperactivity disorder, various compulsive disorder, obsessive compulsive disorder, and many other conditions you could see in the DSM. But executive functioning in an older population predicts the ability to do activities of daily living and instrumental activities of daily living. The things all of us need to do to live independently and get by, highly correlated with executive functioning. Independence, therefore, is highly correlated with executive functioning. And in the world of physical therapy, executive functioning has been studied for at least 20 years. And Mike and I have been doing this work. Mike and I have also been working together for almost 20 years, largely in this space of cognition, cognitive psychology, neuropsychology, and the world of therapy. And we have seen that mobility is affected by executive functioning. Walking speed is predicted by a very simple executive functioning test, and falls are predicted by executive functioning as well. Some other things that can affect quality of life is your ability to interact socially is affected by executive functioning. If somebody cannot inhibit, cannot recognize how their behavior is going to be perceived by others, that's going to have an impact. Driving ability and financial management, that's one you need to watch out for. It's often one of the first observable characteristics that show there may be a problem. But the good news is executive functioning can be improved. And we've actually seen a number of different ways to improve executive functioning, including cognitive exercise, possibly diet, and other factors. But by far, the largest and most robust effects in the literature are the effects of physical exercise on executive functioning. And so we've seen this, like I said, for over 20 years. We've seen aerobic training can improve executive functioning. Strength training can improve executive functioning. And about 15 years ago, we saw that a combination of aerobic and strength training was the best. More recently, we've seen yoga and Tai Chi be associated with executive functioning. Fairly robust effects from both of those interventions. High intensity interval training can also lead to improvements of executive functioning. I suspect many of you listening are more of an expert on this than I am, but the really exciting thing about the HIIT training is just how efficient it is in leading to these outcomes. And then where we are today, dual tasking. I do just want to point out, if you are working with more of a geriatric population, if you're working with a population that does have some cognitive impairments, the effects of strength training and dual tasking can be really profound. There was a number of studies that came out recently showing that even people who have been diagnosed with mild cognitive impairment, that's just one step away from a diagnosis of dementia. 80% of the people that have mild cognitive impairment right now will go on to develop dementia in the next 4 to 5 years. And strength training, dual tasking can actually reverse that. Now, if it gets much worse than that, then it may not be reversible, but there are some very exciting intervention possibilities there. So what is dual tasking? Well, we could define it as saying dual tasking is the simultaneous performance of 2 discrete tasks. We could also say what it is not, and this is really important. Dual tasking is not multitasking. Multitasking is doing 2 cognitive tasks at the same time. So, if I were to, admit people into the webinar and try to, figure out how to do that and share my screen while I was talking, that might be closer to multitasking, and that would not be advisable for your experience, also for mine. What we see is that with multitasking, when people are doing 2 cognitive tasks, actually it's impossible. You have to do one cognitive task or the other. And what happens is, and there's actually a body of research on this, when you switch between cognitive tasks, it takes longer and you are more likely to make an error, as opposed to just doing one task and then doing another task. But what dual tasking is usually one cognitive task and one other task, such as a motor task. And that would be what we're talking about here. And when we can really get into the interventions we're talking about today, you'll really see that we break out the cognitive component and the physical component. So let's watch a simple example of this, and then that'll give us a platform to discuss this. So this is the SMARTfit platform, and we'll be able to see a 30-second timed up and go. Here it is. Now that's a pretty easy one, but what you'll see is, so we have the physical tasks. You need to remember, you need to stand up, walk to the board, come back, sit down while you press sequentially the letters. So the first one was A, and then she needed to remember A while she went back to the chair, sit down. She needed to remember to get back up and do B, and so on. So that would be a fairly simple dual task for many of us, for all of us on this call, I assume. But as we get more impairment, that may be a challenging task. So that's one of the things that we'll see, particularly when Mike is talking more about the SMARTfit technology that uses dual tasking, is the ability to level the difficulty. Not only level the difficulty of the physical behavior, but also level the difficulty of the cognitive behavior. So dual tasking is everywhere. Walking and talking on the phone is dual tasking. Brushing your teeth while pulling clothes out of the closet is dual tasking. Driving while managing children, or shooting free throws while listening or not listening to a crowd trying to distract you. That would be dual tasking. So let's look at some of the research. So, and I like to focus on meta-analyses, but some of these studies are just large studies, so we can focus on some of them too. I really like this one because it compared cognitive interventions with physical interventions in dual tasking. And what the researchers found, looking at 20 randomized controlled studies, found that dual tasking improved cognition greater than no intervention. So no surprise there. But dual tasking improved cognition better than physical exercise alone. So we need to be paying attention to that, because physical exercise really is one of the best ways to improve cognition. And most of these studies actually measured executive functioning directly or indirectly. Dual tasking improves cognition more in older adults. And we've actually seen that in the literature for, very since the beginning of this literature, that the older you are, the more physical exercise improves executive functioning. It probably doesn't improve it a lot in a younger adult, but we begin to see the effects around age 50, and then 60, 70, 80. The effects on cognition, executive functioning, are greater with physical exercise interventions. Dual tasking also appeared to last longer. The improvements lasted longer than single task effects. So that is just cognitive only or physical exercise only. Now, as we age, physical and cognitive reaction times slow, and this can cause unsafe conditions when distracted. They're largely through a process of demyelination, possibly some executive functioning input. We are more likely to have a fall, not notice that the rug is caught up underneath our foot, or we got our foot caught up on a cord, then we have enough reaction time to get it off before taking the step. Recently, researchers reported that the dual task interference, so that's like how much you slow down on the physical when you're thinking about something cognitive, was a reliable predictor of falls in chronic stroke patients. And what you're going to be seeing later in this short presentation is you'll see how we can measure that very easily using the SMARTfit platform. And once again, there's good news is that through training, we can increase cognitive resources and make the motor task more automatic. Whenever we can automatize the physical behavior, then we're less likely to have a problem. So for example, I keep pushing the forward arrow on this button on my computer. I've done that, hundreds of times, enough to automatize that behavior. And I don't actually need to think about that when I talk. In another study, they reported a 12-week intervention that combined physical exercise and cognitive exercise. So it was a dual tasking intervention. And not only did it yield improvements in executive functioning, but they were also able to measure more efficient brain activity in the prefrontal cortex, the dorsolateral prefrontal cortex, which Mike will be talking about later on a functional magnetic resonance imaging. And you can even see that. So efficient brain activity is good. Actually, when you're confused, your brain is more active. When things are making sense and you're not confused, your brain is less active. In another study, once again, this is a meta-analysis that combined 10 randomized controlled studies that assessed the effects of dual tasking on cognition. When they combined all of this data in this meta-analysis, they found that the dual tasking improved cognitive ability, and it was a moderate effect, a meaningful effect. It also improved the ability to do activities of daily living. That was a large effect. And that's huge because that affects quality of life. That affects where you can live. If you can do more activities of daily living, you might be able to live at home. Or if you're a little more impaired or have other issues, you might be able to live in an assisted living environment as opposed to a memory care or skilled nursing environment. And it improved mood. There's a number of studies in this area that have seen that. We know that physical exercise can often improve mood. We've even seen in some studies, some of my published research has shown cognitive interventions alone can improve mood. Not a huge effect, but other researchers have also seen that. And it might be because of inhibition. Whenever you can inhibit, so if you have a negative thought coming in your head, if you can turn that off, then that probably is going to help mood. And there's a body of research that supports that. So that was what I wanted to kind of tee up, looking at executive functioning and then the real world outcomes of that. Now we're going to hand it off to Mike to explore more about executive functioning. Mike?
Great. Thank you so much, Rob. And hey, just before we get started, I want to make sure that now we're exchanged over to my screen and everything is concentrated, no pun intended there. And I want to make sure we can operate that. Can everybody see my screen now? A little motion there. Good. Okay, well, Aaron already took the time to introduce me, so I'm not going to take the time there. I'm happy to see so many familiar names and faces out there on the admissions list here today, and glad to see all of you. I'm looking forward to really getting right into the topic of the day is the differentiation of dual tasking and the sophistication of the science and what we've brought it up to now. And I want to start just by giving you an understanding of the leveling concept that SMARTfit and Dr. Winningham and I are certainly bringing to this platform now. And it's something that's critical, something that you have recognized already in your efforts to work on dual tasking with patients throughout your careers. No matter how long or short your career has been at this point, you understand that sometimes you've actually overwhelmed a patient by trying to follow a standardized dual task performance. Maybe you've had them subtract by threes and they're frustrated with that. They don't like math. They're turned off by it. Or perhaps you've had them try to see if they can count backwards or do the alphabet. And perhaps sometimes they've actually found the task that you've asked them to do in a well-intentioned and meaningful manner to be a little bit too easy or boring to them, and maybe a little bit too gamey. How can this be science? How can this be rehabilitation? How can this be therapeutic? So we understand the principle of leveling then. And when we use the new SMARTfit applications, we understand going right into it, we need to know the educational level, the preferences, and the capabilities and capacities for the individual that we're working with. So when we entertain and engage them and rehabilitate them or prehabilitate them, we want to be certain that we're hitting them right at the level of their capacities. Because all of you know, as according to our efforts to be very therapeutic and prescribe a dosage, that we need to be very person specific and we need to be content specific with what the individual prefers to do and is capable of doing. As you see down there at the bottom of this slide, certainly one of the easiest ways to lose engagement, and we must have engagement to have intensity of your patients, is to either bore them or overwhelm them. So the leveling efforts that we make with the SMARTfit application will include your ability to study this patient's capacity capacities on spatial rotation, mathematics, their ability to be able to hold items in working memory and understand what that capacity may be. You'll look at all of those things, and that will provide to you an asset and subsidize your own clinical judgment as an artificial intelligence to help to guide you through the levels of difficulty for every single individual that you're working with. We know this to be very evidence-based, primarily through the work of Guadagnoli and Lee in 2004. And then even if you go back into the 2006 and 2007 studies, when we look at the principles of neuroplasticity, we know that we must have engagement and intensity before repetitions can really be salient. Now, this is going to be technology that'll be available for all of us on the call today, regardless of your profession, and also extending our ability to engage with clients that are even out into the community and assisted living. And we'll talk more about that as well. So where are we now, and what can we currently do with the technology that we're going to be discussing and that Dr. Winningham has already introduced to you in one of the videos today? We're looking at mild cognitive impairment and the rest of the list that you've got there in front of you. But there is also a later, there is also a future, and we're working diligently in the background for those. And the final bullet point there, more specifics into multiple sclerosis, pediatrics, and certainly we're going to hint a little bit at athletics as well today, vocational pre-screening, and maybe even some considerations of military work as well. So these are all very important prospects that we're holding right now and that we'll be moving toward. So I want to share with you a concept and actually a phrase that I do hope to actually stick into your brain, and that is this concept of movement in the background. And you'll see the trademark symbol right there, and that's in its final stages right now. And I want you to consider what that trademark that we hold means. Movement in the background means exactly what Dr. Winningham talked about, and that is being able to operate something cognitively with a very efficient process in the background that doesn't require any of your attention or very little of your attention. Dr. Winningham talked about using the slide advancer on his computer, and he's done it so many times that it has become automatized. We understand that's one of the key principles to be able to get a movement to be automatized is repetitions. But unless that repetition is salient and meaningful and something that you can easily push into the background, repetitions are only part of the way. Repetitions are only part of the directive that we need to follow to be able to push something into the background. For you to fully learn how to button a shirt without thinking about it or unbutton the shirt as you saw me do, you need to be able to also superimpose an effort, a stimulus for that task to be operated in the background. For example, your capacities, largely in the audience that I would imagine are listening right now, most of you are able to walk without thinking about each step that you're taking. There may be some exceptions, and that's okay to have a range of normal out there in the audience as well. But the only way you got to the point where your walking could be automatized is that you loaded it. You superimposed, you overloaded, and you asked, begged, borrowed, and stole attention from the motor operation so that you can engage in other items in your life. Oftentimes, I'll take an opportunity to talk with colleagues about the very first steps that they ever took at 10, 11, 12, or even a year and a month old. And I asked them to think back about that. And obviously, none of us know exactly where we were and what we did. We are told some of those things, but you understand that the first couple of steps that you took were probably requiring a great deal of your attention. And as soon as those well-intentioned adults, animals, friends, families, etc., stole some of that attention away from you by clapping and cheering you on, your motor capacity faltered. You probably took only a couple of steps and fell. But by sheer demand, stimulus, you were able to soon assimilate both of the tasks together. I can walk and receive praise. I can walk and carry my toys and chase after my dog. And you are able to layer on more capacities and also push the regression of the motor task into the background. So movement doesn't automatically become automatized just by repetitions. We need to stimulate that. And are you satisfactorily, sufficiently stimulating your patients right now to be able to re-automatize and to put their movement in the background in recovery from stroke, Guillain-Barré, concussion, and many others? So we know how to facilitate movement pushing further into the background. And in many of the clients that we're working with, they have a preformed procedural memory before the injury that brought them to us. And so what better rationale to push movement into the background than to go put the movement where it was stored before the stroke and before the concussion. So only SMARTfit is going to be able to level, which I've already described, gamify, engage, and create a measured opportunity for the client to be able to watch themselves and see themselves in a measurable manner improve, and also track the progress in automaticity. So these are important concepts and concepts that we are improving the sophistication of right now. So where are we, speaking of now? We know with this technology how to actually challenge the individual with decision-making capacities, with alternating and simultaneous attention capacities called dual tasking. And we know how to actually measure that in single task fashion. Your cognitive capacity, executive function capacity for this activity, we're going to measure that in isolation. We're going to measure you in physical isolation. And now we're going to combine those. And that sounds like something that makes a ton of sense, but there are less than 5 tests in our entire catalog of examinations that truly do portions of that, and nothing that really does all of that at this point, allowing you to take that step one step farther and to also document and justify. So when we are held to measuring and proving skilled care intervention, and not that we are gamifying on a video game platform, you want to differentiate by showing measurement. There are a lot of imitators out there right now that are looking at what we're trying to do with the SMARTfit and what we already are doing with the SMARTfit. And you have to ask yourself, as one thing, this is not the be all end all, as one thing, can you measure the dual task effect and dual task cost that Dr. Winningham was talking about with us? And so that you can document, and more importantly than documentation, we go back to engagement. If you can't measure the effect and show to your patient, your client, your athlete that they're actually improving in this, how much are you going to be able to engage them by demonstrating their capacity is improving and that their intensity is worthwhile and that their efforts are contributing toward their recovery, pre-recovery, or performance? So by putting movement in the background, we're working with clients along that bullet point list that you see there. And this is a very non-comprehensive list that I'm offering for you. We certainly have individuals that are recovering from stroke that you probably worked with today that are working on improving symmetry, the circumduction, reduction of their swing, the clearance of a limb, the heel strike, or the dorsiflexion angle. But we need to put that movement, as Luthwaite and Wolf told us with the optimal motor learning theory, we need to put that movement in the background. We need to have the goal be the primary. Happens in persons with Parkinson's disease. If they get too focused on the movement decompensates. Mild cognitive impairment. Do we want any individual with less than full faculties in executive function, much less attention, to be driving all of their attention toward every single step? Absolutely not. Concussion, returning back to the academic world, returning back to the field of sport, you're increasing your likelihood for error in academia and injury in sport if you need to devote so much of your attention on your movement. And then finally, something we look at least on this list finally, is how about the athlete recovering from an ACL? How likely are you going to be successful in returning back to your sport to jump up, grab that rebound off of the backboard if all you're thinking about is what position is my knee going to land in as I hit the floor. Movement must be in the background. So we know that the likelihood of falling is going to be increased as movement is in the foreground and as your executive function declines. We can actually measure that with a cognitive timed up and go. There have been many studies that have actually tied that to the mini mental state examination, the MOCA, and many others. So we know that as cognition is degrading for some conditions, that individuals are at elevated fall risk. But unless we stimulate them to put the movement back in the background, all of that heightened risk of having lower executive function is right there in the face of their fall risk profile. So this list is so straightforward. I'm really going to give you a very brief overview of it because I know that all of you can read these bullet points as quickly as I go through them. I'm just sharing with you a couple of concrete examples for each one of these diagnoses of what would happen if the individual that's recovering from or enduring any one of these conditions cannot put movement into the background. And by now, knowing all of you on the list, you've already gone through that entire list while you were hearing me. We're not going to talk about what that principle is, but you know, if you're learning how to be able to golf for the first time, play piano for the first time, or do a new aspect at your work, you want to be able to concentrate first. You want to be able to get that movement going. But for you to be able to put it in the background and automatize it, you can't be thinking about every single cue that your golf swing coach has been telling you. You got to be able to put it into play and put movement into the background. So the contrast of that, absolutely, is part of the error that we make in rehabilitation on a daily basis. Sometimes we cue patients to put the movement in the foreground, to actually drive all of their attention toward the movement. Now, as an early learner in your efforts to regain the capacity to walk, it's absolutely indicated and okay to be able to give patients the overall gestalt of what needs to be done to be able to reorganize their walking. The problem is that we hold on to that attention and we allow the patients to become dependent on that attention to movement specifics for too long in our rehabilitative efforts. We need to fade their attention so that we don't engender that dependence on movement-based attention. We want to throw movement in the background. And again, the volumes of literature by Gabrielle Wolf, Rebecca Luthwaite, and many others will continue to support that point. So the limits of movement in the foreground would include those things that I've actually just populated onto your slide there. And I think it's very evident that if your ability to walk depends on an isolated, clean, and quiet environment, your carryover is going to be limited once you move into an even simple environment with regard to distraction or more complex environments. Your own efficacy and your belief that you're going to be able to succeed in other environments is going to be blunted as well. So again, we come back to movement in the background, where we're stimulating and raising the importance of procedural memories stored down here in those procedural memory centers. Now, some of you will already be familiar with those collections or arenas of the brain that are considered to be the primary procedural memory centers. I just highlighted one of them here, the basal ganglia collection of neurons. We also know the premotor cortex, the supplementary motor cortex, and the cerebellum to be among that list of the most widely populated neuronal regions for procedural memories. In contrast, we have now on this slide the dorsolateral prefrontal cortex, the DLPFC. Now, the DLPFC is actually the main entity that would be allocating and prioritizing and deciding where your attention should be belonging and where you should be focusing at any given time in a single task or in a dual or multitask environment. So let's go back to the SMARTfit platform that we're talking about today and understand the unique features so that we can fully apply what we're talking about here. So we talked about leveling, and we understand that getting the individual to be engaged at their prescriptive tolerance and capacity is part of what leveling means. Now, I've already introduced the concept to you that we would test motor performance in isolation, timed up and go. Cognitive performance in isolation, serial subtraction by 3s, 7s, etc. These are very straightforward concepts for you. We don't often apply these concepts entirely in the clinic by having the individual in a seated fashion perform the cognitive task in isolation. We'll do that in SMARTfit across all of the applications that we've got, and we'll capture that score. Now, we'll introduce the dual task, and we'll combine the same two single task features that we just did. The motor, the cognitive, and now with the measurements of each one of those, we'll look at what the actual dual task cost percentage is by participating in both simultaneously. We'll give you that calculated dual task cost so that you can document, gamify, and then also create the next prescription. Understanding that if an individual has too great of a dual task cost, that we want to reshape and repoint our activities for them so that we don't bore them or we don't overwhelm them. So Dr. Winningham already gave you one glimpse at this. We're going to move into a different feature now, looking at the stage 4 balance test. Now, understand that the three physical activities that I'm going to share with you today are by no means the entirety of the catalog. I'm just trying to keep it all very streamlined and focused for you in a very short presentation. You will, and many of you are astute enough to recognize that the three videos that I'm going to share with you here today have a unique commonality. And I'm going to ask you to be challenging yourselves to see what the common thread is before I share that with you. Now, by doing that, I understand that I'm enticing your attention. Here's a video you have not seen. So she's going to participate in the fourth stage of the 4-stage balance test, attempting to hold for 10 seconds. Now she's going to cognitively, in isolation, attempt to score as quick as she can the cognitive performance in isolation. Now she's going to do both together. As you see in the left panel, physical and cognitive combined. Now, purely for the economy of space there, we label that as 2 falls, and we know that those were losses of balance, which just takes more characters to spell out. And keeping that in mind, I want to share with you the next screen here, which actually is an initial dual task report from which you can translate your documentation right into your EMR. Understanding that what we're organizing here from the top, just some demographics profiles of the individual. Now we look at the physical only. That's identified and abbreviated as the PO at the top under the first broad gray bar there. She didn't have any falls. And again, I want to make certain you understand that's losses of balance. No one will see a fall for her on that video. Then we watched her perform the cognitive only task seated. And her score in the calculated time was a 30. Her accuracy was 100%. She made no errors. And her reaction time was 1.4 seconds from when the stimulus was presented to her accurate response. So we saw that she also made 6 repetitions or touches during that time. Now, it may be something that's of interest to you right now, but I want to let you know that we can standardize this now. That's one of the main things that SmartFit's going to be able to do is we're going to be able to standardize the test that you're looking at there. So the cognitive application during the testing that we're doing to be able to create a huge database is going to give us something where we could have her count backwards in letters, count forward in letters, count up or back in numbers by just one interval, or up or down by 7s or 3s. But I want to let you know, in order to be able to level someone and get a huge database, all the tests will need to be the same for us to participate. Then when you're engaging with your client, we're going to be able to ascribe any number of different levels for them. What you're seeing here in the cognitive only and on the left side of your slide right now is level 3. That's the third level of difficulty that we've assigned, so that in the leveling process, when we start with the individual and we know their capacities, we can introduce the appropriate level of testing for this individual. Level 3 testing will stay in its own database so that we know that we have like testing even across different diagnoses, and then we can refilter them accordingly. Now, the third thing that you watch that individual do is attempt to stand on one leg, the 4th stage of the 4-stage balance test, and also participate in the cognitive task. Now you're going to understand that her score was 25, which means she got 5 points for every correct score. She had 100% accuracy. But now I want you to look here. If we didn't have the capacity of SmartFit to introduce and to also measure this for us, we wouldn't know that her reaction time slowed down. It took her a difference of 1.4 seconds. And then the second time in the dual task, looks like 8.6 seconds on that, 9.6 seconds on that. And she was able to score 1 fewer repetition. She had 0 falls in this performance right there. And in that effort, if you were to look at this as the scoring sheet, and this is just an example of the scoring sheet here. In the example that we saw her make 2 touchdowns, 2 losses of balance, not touchdowns as in 6 points, mind you, in football. She made 2 contact points with that leg that was supposed to be off of the floor. Now, that will be measured then also in her performance and dual task cost. But let's look at the bottom. This is where it's so critical, and one of the absolute novel things that SmartFit offers. We look at the cognitive performance, and we see that her performance went down by 17% when you look at the raw score, the score of 6 versus 5, single task versus dual task. Now we also look at the cognitive accuracy. Fortunately for this individual, she scored 100%, made no errors, compared to 100%. And if we just took the total score there, that's where the story would end. But now SmartFit can give you the maximum volume, how many times did she interact, and also the reaction time. And this is what's huge right here. The sophistication tells us that she had a 27% reduction in her speed of reaction time. Again, that 1.47 changing down to the 1.86. And so now we can calibrate, calculate, and re-prescribe based on the performance. So don't worry about determining who should be prescribed dual task and who should be engaging, because dual tasking really, and this is me saying this tongue in cheek, is actually only relevant for the classes of individuals that you're talking about there: athletes, employees, drivers, students, frail elderly, and so on. People that actually need to improve their performance. Again, athletes, vocational performers, and many others, drivers, novel drivers, which is a concept we're already working on with state drivers associations and drivers examination centers, or individuals that need to slow a disease progression. So we have 2 categories there of individuals: people that are performing well that need to improve, people that need to slow a disease progression, or people that need to recover from injury. Well, that's why I'm saying this likely very tongue-in-cheek for all of you. You can see that's pretty much going to include an everybody set. Now, let's look at the second video. And remember, remind yourself that you are looking now for some commonality. You watched the 4-stage balance test. Now we're going to watch a video in the same organization for the sit to stand. On this video, I'm going to stay quiet and I want you to watch the video and look for the instructions and the summary features that are happening on both sides of the screen. We're going to watch the 30-second sit to stand. Twelve repetitions. Now, she's actually engaging in the square root. Yes, we can make it that difficult. Now she's combining both. She's going to look at the square root Q that's in the center of the board, and she's going to tap the answer in the periphery. Now, let's join in together and see how she performed, okay? So again, the scoring sheet that you're now familiar with will look at the top 12 repetitions, and this scoring sheet is in fact for the same video that you just saw. 12 repetitions, physical only. Cognitive only, score of 75. So she was able to engage enough to get 75 points there. Her accuracy was 100%. Her reaction time, 2.1 seconds. Her repetitions, 15 times 5 points for each correct answer, got us to that 75 points. We could stop there and say, wow, she's got no problems whatsoever. We don't see any dual task cost. If we go down and combine this, and we see again that she had 12 repetitions. If that's where we stopped, that's where we can document, and that's all we can speak of is the 12 repetitions. Look at that third column down there, the third row down there, I should say, in the dual task. Down at the bottom of that, repetitions, and that's where a lot of our dual task costs fall short. Our dual task tests that are in the clinic, they fall short because they only give us an impression of how the physical was carried out with a superimposed cognitive. But here, SmartFit increases the sophistication for you and measures all of the attributes, the physical and the cognitive. So now we know that her score was 55. So she was able to engage in 11 correct answers rather than 15. Her accuracy was 92%, so she made one error across there. And her reaction time went from 2.1 seconds to 3.08. This is an extremely proficient 65-year-old who's very high level, but we're even able to measure that so we don't have a ceiling effect. Let's move on. Now you've seen 2 tests so far, and I know you're ready for the third one. We're going to look at the timed up and go shuttle test. If that sounds novel to you and you're scrambling your brain right now to find out, wait a second, how did I miss that? It's because that test is currently actually in studies right now, is being researched right now in collaboration, myself and a few other universities. So imagine that it's the timed up and go test just done in sequence for a defined period of time. All right, let's watch this video. So here we go. Physical only first, you know that's coming, right? So we're gonna watch her interact with the board. You saw this when Dr. Winningham showed you this video earlier. Every time she touches the board, SmartFit is actually counting a repetition. You'll see the scoring sheet up there now in that computer. Now you're watching her do the seated effort of the cognitive test. Now we're going to ask her to combine both. Comes to the board, searches for the A, comes back to sit down, comes to the board, has to think about where she is, searches for the B and scans. Does it actually load or affect her performance in gait when she's attempting to do both? Let's find out. So her score, 5 repetitions, travels or trips or laps to the board. score of 75. Accuracy, 100%. Now, when we move down into the cognitive, she got a score of 75. Again, 15 repetitions while seated, made it through the alphabetical. Now we're down to a level 2 here on this, lowered her difficulty, 100% correct. 1.83 seconds performance and 15 repetitions. Now her score, when we're combining both of those, she scores a 20. She's able to get 4 repetitions. Her accuracy, 100%, very important to us. She did not lose track of the alphabet. And the reaction time, 8.45 seconds when combining the two. Now, I want you to be thinking about that, and we're going to talk more about the combination and the deeper levels of the examination that SmartFit has now and what we'll be moving into in the future. Just to blow your mind a little bit, think accelerometry. Think actually putting body-worn sensors on the individual's limbs, perhaps actually at the shoes, at the ankles, at the shank, and also at the thigh, so we can study her quality of movement as well as her quantity of movement. So again, we're moving places, and I want to make sure you understand that that sophistication continues to grow in the background with the SmartFit subscription. So dual tasking, to bring us toward a summary of what we've talked about and add just a few more concepts. Dual tasking, we know, measures the physical and cognitive. So it is actually giving the stimulus for the recovery. If you don't ask someone to put movement in the background, it's not going to automatically happen. So we need to make certain that we are providing that stimulus. And that can be for recovery, for regaining some capacity that has been damaged because of learned non-use. If you had a stroke 2.5 years ago, you're probably not challenging your dual tasking and your automation, but that capacity may mean that it's still in there. It wasn't lost directly from the stroke, but it's lost indirectly because of your activity changes. And again, as I've mentioned, the stimulation that's necessary to slow degeneration in MCI and many other degenerative diseases. So we're currently ready for and applying this as on an individual level in long-term care, and as you can read on the slide there. But what we're cueing ourselves and already building for is including in vocational rehabilitation, which I've alluded to, pre-employment, which we are working on right now, athletics, be that for drafting and scouting, as well as performance, and as a matter of fact, also military sport recruiting and continued training. So dual tasking helps you put the movement in the background for all of these applications. I want to pick up on the concept of gamification now so that we can help to engage and ramp up the appropriate level intensity for the individuals that you're working with. And we also want to lean heavily on all of those human tendencies and the behavioral economics behind engagement so that we can maximize the neuroplastic opportunities. So if you're not measuring dual task performance, you can't share with your patients that they're improving. And if I don't know that what I'm doing is causing me to get better, how likely am I to put forth full 100% intensity again and again on homework or on clinic work? Gamification is critical for that by using the dopaminergic reward loop. And we're going to talk more about that in a moment. Gamification works because we use that human tendency, behavioral economics, to be able to compare my best score and compete against myself and see if I can one up. We know that from video gaming, and we'll talk more about that in a second. It improves our capacity to stay motivated and to come in and to work harder again. And we use the SmartFit capacity to level and prescribe so that we can keep that individual challenged, but also giving them a personalized capacity to be able to work at a level that satisfies their personality. Too many errors, you've lost me. Too much success, you've lost me. Work on optimizing that for the level of difficulty, for the condition, and for the person. So we can apply this across any type of rehabilitation, and we know that especially from Guadagnoli and Lee, 2004, as performance goes up, practice and task, difficulty must continue up. But if we bring task difficulty up too early, performance comes down, learning goes down, motivation goes down, and we have a depressed individual who's working on an environment that seems burdensome and overwhelming. If we keep the individual challenged, we keep them attentive, and we keep maximizing the neuroplasticity because of the dopaminergic reward cycle. Here's one of the few times that you'll ever hear me actually read to you on a slide from Indre Viscontis, neuroscientist and TED speaker. She is a soloist and vocalist in the opera. And Indre, from her TED Talk, said, the caudate is awash with dopamine when you're leading up to the special moment that will give you the chills. She's talking about her vocalist performance and singing on stage. But when you get to the moment that gives you the chills, there's a dopamine spike in your nucleus accumbens. So the audience knows the crescendo is coming. The performer knows the big note is coming. And getting yourself prepared for that brings dopamine through the caudate toward the nucleus accumbens until we finally hit that dopaminergic reward cycle and reinforce the effort and the performance. We know this reward circle to be much more complicated than just the caudate and the nucleus accumbens, but suffice to say for today's performance and your understanding, and many of you out there are actually well studied in this, we know that it is very intricate, including the DLPFC, the hippocampus, the memory, and really our episodic memories for what we have experienced in the past. You want your patients to come to therapy looking for and yearning for that next successful opportunity. So I'm going to coin a word for you because I'm apt to do that, and it's called gamification. It's actually putting gamification and engagement together. And I didn't develop that concept, but yes, that term we did. The person that really developed that concept said this quote, "All the best games are easy to learn and difficult to master." And who was that? Well, that's this individual. And if you don't recognize the quote, that's okay. And if you don't recognize this individual, that's okay, because he has captured a great portion of your lives one way or another. This is actually Atari and Chuck E. Cheese founder, Nolan Bushnell. Now, some of you are old enough to have played some of the original Ataris. Dr. Winningham and I would be of that age. But since that technology has continued to evolve, what you've played in your lives has lent itself on this initial gamification concept. And if you haven't done the Atari, certainly you've been to a Chuck E. Cheese or some sort of arcade. So you want to make a game just like what we've done with SmartFit. We've made it easy to learn for the therapist, for the coach, for the activity director, but also for the patient, the student, the athlete, and the vocational, the worker. We've made them difficult to master, just hard enough to keep you thriving and engaged. So summarizing here, we've looked at mild cognitive impairment today, and we know that just like Dr. Winningham told us, we need to combine physical movement and cognitive stimulus. We looked at stroke, and we understand that individuals pre-stroke have procedural memory centers. And most strokes are not actually involving the procedural memory centers, especially bilateral. Procedural memories will be preserved for the most part in many strokes. And we have to task ourselves. Are we currently utilizing those preserved procedural memories in our rehabilitation to get this person back to automized? You have to ask yourself that. And so we want to reduce the internal focus and turn it toward the outcome and the game and the experience in all forms of function. Parkinson's disease. Again, many different applications, your capacity to determine your vertical generating power, speed, all of these are dependent on your ability to be able to automatize and shift out of the cognitive focus on your movement. Many of these individuals with Parkinson's disease are similarly and doubly affected because their procedural memory center is impaired, so in the basal ganglia, as well as the DLPFC, which also depends on dopamine to be delivered. So what did we learn? Final slides in summary before we take so many of those questions that we have populated that we're happy to take here tonight. You saw us apply this in a timed up and go shuttle, a 30-second sit to stand, and a 4-stage balance test. Now I'm going to task you to remember right now what these things have in common: timed up and go, 30-second, and 4-stage. And I imagine someone's going to populate the chat box, if they haven't already, with the answer of what these have in common. This is only a very, very, very small aperture of what we have in the SmartFit catalog now for movements that we're going to store into the background. But I want you to consider that it doesn't even come close to stopping there, because we could have done repeated floor to stand, and we could have done a whole number of batteries that you might be able to ask for your SmartFit application. And in the very near future, we can actually conduct a full assisted living physical screen, cognitive screen, combined screen to determine what level of care this individual will need. So we put movement in the background as the summary today, and you heard about automation and procedural memories. You heard about implicit learning, which is how we develop procedural memories, and we know that that can only be facilitated through the dual task stimulus. So finally, we understand this so clearly that we've put dual tasking into every single aspect of SmartFit, geriatrics all the way through vocational. So with that said, we are ready at this point to field your questions. So I'm going to turn it back over to Aaron to help us moderate. We'll bring back on Dr. Winningham, and we're absolutely going to say no questions are off the table. Hello to all you friendly and familiar faces out there. I finally get to see you again. I'm tired of staring at my screen. Let's have it. Let's hear some questions.
Awesome. Thank you. Okay, so I'm going to scroll back up. Do you want me to just kind of read through the ones that are in there?
We'll take them all. Put the hardest ones at me first.
Oh man, there's some
and
good
Dr.
ones.
Winningham too.
There's some doozies.
All right, let's hear the doozies.
Okay, let's see. Where's the first?
While you're searching, I want to say hi to Joni Berry and Claire McLean. No matter how you spell your name, Claire. I think I saw Keenan out there and Christy Ross. Hey, Keenan. All right, go ahead. I'm ready for you, Aaron.
Okay. Jean Tanjali. I hope I want to say your name right. I'm so sorry.
Gitanjali.
Gitanjali. Thank you. Gitanjali. What's one thing Mike, that has helped you in making non-automatic automatic again for your patients?
Wow. What's one thing that's helped me make non-automatic automatic again for the patients? So many things. I'm going to start with actually the absolute clear functionality and meaningfulness of dual tasking. So many people can understand, okay, I can learn how to concentrate and walk, but what happens when I get out in the world? And so one of the things that I will say to you to answer that is education, to be able to just say to the patient, this is practical. This is real world. I want you to be able to live. And so what I'm going to do with you is I'm going to overtrain you. I'm going to load you up so that your walking is indefensible and it's insulated, so that when you're done going through what I've got for you here in rehabilitation, you're a world beater. You're not going to face nearly as complicated environment out there once we're done. So that's one thing. I could go on, but I'm going to stop at the one thing on that.
Mm-hmm. Someone typed a private question to me, but it was for you, and she wanted to ask, or he or she, I'm not sure. How does a PT manage ceiling effect of a patient, quote, memorizing the backwards by 3s or by 7s? How can we keep the cognitive task novel?
That's great. Rob, do you want to field this one, or do you want me to get it? This is.
Well, I know you have a lot of ideas. Now, I was going to say on the previous question too, in terms of automatizing, I think one of the most important things is airless learning, think constrained induced movement therapy. We need to get it right, and we need a lot of rehearsal trials. And one of the things that we have learned is that using caregivers to try to get more trials in is a great way, because you might need 100 trials to automatize a behavior. You don't have that much much time in the clinic. And the caregivers, they often want to do that work for people. So I would try to get them involved and tell them the benefits of that. But I think
just so you know, let me interrupt for just a second. This is not actually a replay of the vice presidential debate where Dr. Winningham goes back and actually answers the previous question. Go ahead, Rob. Rob and I are such good friends. Go ahead.
Yeah, no, but if Mike was to answer this question, I wonder if he would say, have them go back by 2 letters or have them go back by 3 letters from Z. So that will immediately make it more difficult, because you're absolutely right. We know that people are training for the tests on the slums and those commonly used tests. I've caught them in Mike's clinic doing that before I did an evaluation with them. So we can make it more difficult. And I also saw there were some questions about, what is available in the SMARTfit suite of activities for dual tasking. And there are many, many activities. So we'll be able to choose the ones that are more difficult, but that's an example of something we could do.
Yeah, and that's exactly right. And Aaron, the catalog is so large and continuing to grow that the individual would have a very difficult time keeping up with the volumes of different tasks that we can do. So just so the users and individuals that are pre-subscribers, you like that term, pre-subscribers? I like pre-subscribers that are listening out there today. You have to understand that we're not only going to be taking calculations and subtractions by 3s. We actually have different batteries of tests that you're familiar with, but you haven't trained yourself for, and there's no way to train yourself, such as the Stroop effect with a color word mismatch. No way to actually memorize what to do there. In addition, we have activities that look at flanker test. Which way are most of the arrows pointing? In addition, we have activities that include being able to match 2 symbols out of a full battery of 9 that are on the screen, and the immediacy of the reactions. No way to do that. Concentration tasks, spatial rotation tasks, and we could go on.
Okay. Nasim asked, how much would oculomotor deficits influence performance?
Great. Nice thing there is that when you're leveling the individual in their cognitive only opportunity, then we get an idea of what their capacities are, so we don't have to test them in dual task against some artificial baseline. So if your visual capacities, scanning, and we could go on to the different types of visual capacities, if those are actually interfering with your performance, when we dual task you, we're only testing you against your baseline capacities there. So it's not going to limit us at all. And the other nice thing to say about this is that in SmartFit's flexible 9-window screen, we can actually ask just the left side of the window to be populated, just maybe the left-hand column and middle column for 6 windows. Or we can just do a superior view of 6 top windows. And I could go on about that, but I won't belabor that point.
Okay. Will you say, I want to pronounce the name right again, Gentali?
Gitanjali?
Gitanjali, I'm so sorry.
Yeah.
I really want to say it correctly. Mike.
He's also another good friend of mine. That's the only reason why I know how to pronounce that. Yeah.
Mike, do you have access to normative values for single tasks and dual tasks for these tests, precisely for the age group you desire?
So the answer is absolutely yes, right now. It's starting to build right now. And it actually comes from the subscribers and the pre-subscribers that the data collection living on the cloud is actually occurring as we speak. So this is going to be a huge database for persons with Parkinson's disease is one category, easy to be able to sort out. Persons over 65 years old, easy to sort out. So it's actually populating right now as the normative tasks roll out or being used currently.
Melanie asked, does your awesome system include everyday cognitive tasks like recalling a grocery list while doing something physical?
Good suggestion. Yes, starting tomorrow. Yeah, that's where we benefit so much. Oh my gosh, I can't tell you how great the SmartFit crew is of being able to adopt things that Dr. Winningham and I have thrown at them and suggested. So the answer is all that gamification is continuing to be built in the background. So their build queue is very large right now that we've had them build up. So we've got a lot of things that are currently in stage, and we have something very similar to that that's currently in queue. But if you were to subscribe right now and play the most updated version, it doesn't have that absolute feature right now. So
Well,
digit span forward, digit span backward, and many things that are related to that. Go ahead, Rob.
Well, and I'd like to point out that you can still do those types of activities. You can get a pre-test on SmartFit, you can train on SmartFit, but you can do some more of these real world things without SmartFit. I remember over 15 years ago, we were working with a group of geriatric patients, and Mike got every one of them a grocery bag, and he put different colored tennis balls in there, and then he wrote different numbers on them. This was before probably any of you even heard of dual tasking. And we had a group of 10 older adults walking the block around his clinic where we'd be having conversations with them. Students from the university would be chatting them up, making sure they were safe. And then Mike would yell out, pink tennis ball, or a tennis ball with number 2 on it, trying to bring a real world activity that is looking into your purse while you're walking, having a conversation into the training environment. So I would throw out that possibility as well, in addition to the SmartFit.
Yeah, good point. Yeah.
All right. David asks, what is the literature on generalizability for a task like this sit to stands? Or should the intervention be task specific to activity / participation impairments?
Yeah, so that's a great question. And the big thing there is, remember, we can come back to the SmartFit. Just this kind of folds right off of Dr. Winningham's last comment. It doesn't mean that all of your therapy needs to be right in front of the SmartFit, but your only way to understand what level or how to do another progress test or how to re-gamify with this individual needs to be right back there in front of the individual. Your therapy can still carry over out into assisted living or into their residence or into your clinic. So the functionality can be carried out in front of the SmartFit, or the functionality can be carried out into the gym. And then you can come back and dual task with them and re-measure their capacity. So you don't need to feel like the SmartFit has to represent all of the different functions. But believe me, we've got sit to stand, timed up and go, tightrope walking, single leg sit to stand, floor to stand, and many things that are available for us. So don't feel it has to represent all of it. Point well taken, and thank you.
And I want to add to that, because it's a very important point about executive functioning. If you can improve executive functioning, then that will generalize to activities of daily living. So this is really important. We don't want people doing Sudoku and just getting better at Sudoku. We want them to improve their executive functioning overall and have it generalized to tasks that have never been trained. And if you do this right and you truly train in dual tasking, then it will generalize beyond the tasks that were never trained.
Mm-hmm.
Okay. Sheila says, these are very artificial measurements. How will they translate into reduced falls in everyday life?
Yeah, that's a great question right there. And one of the things that Dr. Winningham led with, and that I also continued with, is that research shows that if we don't actually stimulate individuals with novel cognitive tasks, we won't improve them. So where we are in science right now is that we utilize these tasks to be able to create a standardization and to create a prescription. So many of the tasks that you will see that we're going to be working on are actually much more prescriptive in nature. And then we have the gamification side of things. So the only way to be able to create a reliable, and just like Gitanjali was talking about, a normative database, is that if we use an artificial test that can be replicated every single time. Then we break out of the artificial test, or the artificiality, if you will, to coin another word, and we pull into function when we want to engage with the patient. So we pull into function and we look at their ability to be able to remember that grocery list and what have you when we're gamifying. Testing needs to be reproducible and needs to be very consistent and needs to be artificial. But I'm a very huge proponent, and I think everyone on the screen, on the performance today, would also agree that therapy needs to be functional. So you're asking two separate things there. You have to have reproducibility so that you can be reliable. Therapy needs to be gamified in function. This is meaningful in my life. Yeah. let me take you on one small thing there, because I know we've got a lot of other questions. We actually have the capacity to be able to take that SMARTfit board that you're seeing and throw it out onto different pods and interactive devices out on the floor. So we can have someone kick a soccer ball at an upright podium that is holding one of the SMARTfit computers, and they're only supposed to kick toward that screen if that screen is actually posting the number 3 in the uniform number for their team. You think about shirts versus skins. When I was playing, pickup basketball as a kid, or you think about, are we in the home uniform, the green, or are we in the white, the away uniform right now? And I don't remember who to pass it to. Oh, number 3's open. I only want to throw it to a person that's open. Whoops. I need to make certain that these things are practical, and we can do that in soccer, basketball, and in many other rehabilitative efforts. So we actually are programming the therapy to be very functional as well, so that go, no go and decision make is actually something that's real life as well.
Shannon asks, do you have to create your own cognitive challenges in it, or are there categories to select from? Other than the tug, are there any other ways to combine this with ambulation or other dynamic tasks?
Yeah, so you can combine them and superimpose them with anything you would like. Imagine that you were going to do a tandem tightrope walk to get up to the board. Imagine that you're going to do a walk with head rotation to get up to the board. Imagine that you're going to have them do a 360-degree turn before they come up to the board, and then they're faced with a subtraction to do. We can go on and on with that. And so the ability to be able to gamify that is limited, but only limited based on your imagination.
Okay. How much time do you have, Mike, for the...
I'm good. I'm good.
Okay.
Yeah. I got to get to bed by 11:15, so I'm okay. Good.
I have something at 7. I have a video conference with someone at 7, so maybe
I can
finish by then.
Post this. It's all good. It doesn't matter.
No, I need my Zoom to do it.
Oh, okay. Claire?
Well, that's our Zoom.
I got you. No problem. Hey, we've got 11 minutes left. Let's use it. Let's go.
Okay. Let me see where the next question was. Okay. Let's see. Gitanjali asks many questions. Mike, do you get too in the weeds of cognitive tasks like task switch and task inhibition? And she was also asking about gamification. What if in the principles of optimal theory, your patient is not compliant for gamification? What do you do then?
Yeah, so I'll take part of that, and I want to share that opportunity over to Dr. Winningham as well. So task switch, go, no go, inhibition. One of the main things that we love right now, of a volume of things that I could talk to you about, is, again, Stroop color word. Imagine playing at the board and the word white is written in a green circle. And the cognitive set that you're playing with right now says to you, I want you to select all of the circles, windows, computers that actually show a dissonance, that show the color and the word are a mismatch. And so you hit the word white when it's in a green circle. You hit the word blue when it's in a yellow circle. You hit the word red when it's in a white circle. Example therein. So we're doing a lot of that dual task switching. And then you get primed up into the cognitive set, and then the cognitive set switches on you if you have qualified for that level of difficulty. And it says, now hit all the ones that match. Hit red inside red, hit yellow inside yellow, blue inside blue. So we do those types of things. I don't want to dominate the call, so I want to let Dr. Winningham additionally take part of that question as well.
Well, I think you did a good job, but Mike and I were constantly looking for ways to get at inhibition. And anytime you switch the task, you have people do it one way for a while, then you have them do it a different rule, that's going to be inhibition. And it's so important, cognitive and physical inhibition for quality of life. And the SMARTfit platform allows us to do a lot of different things like that. We can do color, we can do symbol, and even something as simple as just doing a normal flanker test, and then we can do an opposite flanker test and build that in. And so that there's a whole suite of activities that tap into that inhibition, and it's a slightly different part of the brain. One of the things that Mike and I have tried to do is look at all the different aspects of executive functioning and build activities that exercise those different aspects. And so inhibition is important.
That's great. Thank you for adding on to that too.
JJ asks, time for the big question. What is the cost for the system?
Oh, you know what? I have no idea. I was given one to actually do so much of this development, and it's been so long ago too. It's not that I wouldn't remember it, but I have no idea. Now, obviously, I seriously have no idea. Now, I think Kathy's actually on the line right now, and so she could probably help us out with that or get you in contact with somebody. So Melanie, yes, it's available for purchase. Aaron, I'm not certain I could answer that at all. I have no clue whatsoever, but somebody can help us out with getting, maybe we can post an email of somebody to contact about that. Tom West is on the line. Hey, Tom, could you unmute and maybe guide listeners for how to do that? I think I saw you. Yeah, so Melanie, I'm a developer, and Dr. Winningham's a developer as well, but yeah, I'm not a salesperson. Hey, Tom, thanks for joining.
Yeah, Mike,
Go ahead.
thanks. Yeah, I think actually the prices are actually on the website.
Oh, okay, wow.
And if you go to smartfitinc.com, that will guide you to you pick the choice that says medical, and it will guide you to that particular portion of the website, which is where you guys would be focused on, and then pick choose the products and go right down the products. The mini is the most popular product. That's the one that you've got, Mike, and then the strike pods in addition. So that'll give you the base MSRP on the product. Hopefully that helps you.
Perfect. And just use the coupon code Tom West.
There you go.
All right. Very good. Thanks for the question. But I just seriously don't even know.
Okay. And I just want to clarify that Claire and I did not get a SmartFit system, and we are just hosting the Zoom. We have the Zoom account. So I don't have that information nor a system either. So.
Yeah. And I do want to respect your time. I know you need to get on one at 7. So I don't want to pretend that we can go all the way up to 7 for you. So just be respectful of yours there.
Okay, let's see. Joseph asks, is there any effort to create a list of the top required motor plans to get through modern mobility? I'm looking for a movement dictionary in which to sequence movements into combinations like movement sentences for full tasks.
Mm-hmm. Yeah, so I'll tell you, our catalog is going to be huge in terms of that, but I don't feel that I can answer that question because my attention, no pun intended, has been so directed toward the dual task and building this out that I don't feel that I'm qualified to start to give you a direction to look for that. So it's great, but I don't know of a list for that right now.
Okay, JJ asks, curious about the 30-second physical tasks. Do we know that is a good length? I wonder about doing these for a little longer. I do a 4-minute activity and add a dual task so that attention and focus are looked at as well. Is that too long?
Yeah, as a matter of fact, that's great. And that's part of the usability and customizability here. We can take any one of the play mode activities. Remember, I told you already, the tests need to be reproducible and consistent. But any one of the play modes can be developed into any length that you want. You can do 30 seconds, 60 seconds. You can do 2 minutes long. You can keep going on from there for more sustained attention. There are 6 different aspects or attributes of attention, and selective attention, divided attention, focused attention, and sustained attention are just part of those, and we're representing those as well. So the ability to filter and split and divide and endure, we respect.
Okay, and I think this might be about the last question. There's some discussion that people are having in there too.
Okay.
Gatanjali asked, Mike, what is it you want the researchers to test when it comes to dual tasking to take it to your clinic?
Cost is the biggest thing. And then we can go down from there. So cost is the absolute necessity, and you can't measure cost unless you've measured each of those in physical and cognitive. And now you'll see what we're doing to break that out is we're taking cost to the next level. We're taking cost to accuracy. How accurate were you as compared to your single task? Then what Dr. Winningham and I have actually coined as MACuracy, M-A-X, MACuracy. And that means the volume, because I can get 100%, but only answer one question. but what was your volume? So then if I were a researcher, I'd want to be able to break that down then too. And then reaction time. So I can give you the 30,000 foot and I could say measure dual task cost. And then I can come down to 15,000 feet and I can say accuracy. And I come down to 10,000 feet and I can say accuracy. Then I come down to 5,000 feet and I can say reaction time. And we can keep going on down the road from there. And I get a little excited about these things. So, you know.
That's awesome. Well, there's lots of people saying thank you so much and really appreciating the lecture. And it was really great. And we appreciate both you and Rob taking the time to come and educate everyone on the research and all the things that you've been working on. And it was really nice. Thank you.
Yeah. Hey, thank you. And hey, email me directly if you've got questions that you want to take offline. It's just mike@northwestrehab.com. Spell it all out, northwestrehab.com. And I can at least share my address, and I'll probably kick most of the questions over to Dr. Winningham anyway. All right. Hey, thanks everyone for your attention tonight. Really appreciate the energies and just looking forward to continuing to build a better platform for all of us with your support. So you guys have a great night.
Thank you. Thank you all for coming. Good night.